The discussion today is post-Caesarean pregnancy. Pregnancy with prior history of Caesarean delivery is very common, and these are referred to as post-Caesarean pregnancy cases. It is a type of high-risk pregnancy and should be managed in a tertiary care center. Effects on pregnancy and labor. As such, no significant alteration in the course of pregnancy and labor is usually seen. But still, we may encounter the following complications: abortion, preterm labor, need for repeat Caesarean section, placenta previa, adherent placenta, postpartum hemorrhage, peripartum hysterectomy, and scar rupture. Coming to the management of a pregnancy with prior Caesarean delivery. Planning for future pregnancies and delivery route should begin with preconceptional counselling. She should be considered as a high-risk case and should have regular antenatal visits. Previous history should be properly reviewed and previous operative notes are to be seen so as to assess the risk. And these risks are to be reconsidered as the pregnancy progresses. All antenatal counselling that is done should be done with proper documentation. The ACOG and the Society for Maternal Fetal Medicine recommend delaying non-medically indicated deliveries until 39th completed weeks of gestation or beyond. As per the American Academy of Pediatrics and the ACOG, trial of labor after cesarean should be undertaken only in those facilities with staff and resources which are immediately available. A shared decision has to be taken in these regards by the obstetrician and the patient party regarding the mode of delivery. So what are the management options which are available? We may go for a trial of labor after Caesarean section with the goal of achieving vaginal birth, also known as VBAC. If Caesarean delivery becomes necessary during the trial, then it is termed as a failed trial of labor. And the second choice that we have with us is elective repeat Caesarean delivery. The ultimate decision should weigh clinical factors which are known to influence trial of labor after Caesarean section success, as well as the benefits and the risk. Coming to vaginal birth after Caesarean section. So what are the factors that favor its success? Women with prior history of vaginal delivery are said to have a success rate as high as 87%. The spontaneous onset of labor in the present pregnancy or a cervical dilatation of more than or equal to 4 cm at admission. Then, if the prior indication of Caesarean section was a non-recurring indication. With breech, there is 90% success rate. With fetal distress, the success rate is as high as 80%. Then, the pelvis should be clinically adequate. Prior transverse incision. Current preterm pregnancy is said to show a similar success rate with lower rupture rate and also with lower fetal rate, the success rate is more. Coming to the factors disfavoring success of trial of labor after Caesarean. More than 2 prior Caesarean deliveries, T-incision, low vertical or unknown incision, transfundal surgery, more than 3 first trimester previous miscarriages, short interdelivery interval, estimated gestational age of more than 40 weeks, maternal age of more than 40 years, recurrent indication of Caesarean section such as contracted pelvis, uterine malformation, cervical or vaginal stenosis, induced labor or cervical dilatation less than 3 cm on admission, presence of certain obstetrical conditions like placenta previa, malpresentations like breech presentation, preeclampsia or eclampsia, postdated pregnancy, macrosomic fetus, fetal death, and multiple pregnancy. Then obesity. Then medical diseases like diabetes, epilepsy and cardiac disorders. In all these conditions, a cautious approach is required. What are the contraindications to VBAC? Absolute contraindications are previous classical Caesarean section, previous history of uterine rupture, or if there are other contraindications to vaginal delivery such as placenta previa. Next, the relative contraindications, where the decision is on a case-to-case basis, which is to be taken by a senior obstetrician with access to details of previous surgery. This includes complex uterine scars or more than 2 prior lower segment Caesarean section. Advantages of VBAC. The success rate is as high as 72 to 75%, and it is 85 to 90% in those with a prior history of VBAC. So this is said to be the strongest predictor of success. A successful VBAC has got fewer complications than an elective repeat Caesarean section. However, a failed trial of labor after Caesarean has got more complications than an elective repeat Caesarean section. The benefits of VBAC are avoidance of a major transabdominal surgery with its inherent risks such as hemorrhage, operative injury, anesthetic complications, then reduced length of hospital stay, decreased need of blood transfusion, decreased risk of abnormal placentation, and decreased need for successive Caesarean delivery in subsequent pregnancy. Complications of VBAC. First, the maternal complications. The most important one is risk of uterine rupture and dehiscence. This is the most common dreaded complication, risk being around 0.5%. It is said to be complete when all the layers of the uterine wall are separated, and incomplete or uterine dehiscence when the uterine muscle is separated but the visceral peritoneum is intact. Then increased rate of hysterectomy, blood transfusion and infection. Compared with the successful TOLAC, the risk of these major complications are fivefold greater with an attempted vaginal delivery that has failed. Risk of anal sphincter injury is around 5%. Risk of maternal death is 4 in 1 lakh. Fetal and neonatal complications. Perinatal mortality. The perinatal death rate is comparable to that of a nulliparous woman at term. Then there is a risk of hypoxic ischemic encephalopathy. Then low Apgar score and increased NICU admission rates, and neonatal respiratory morbidity, the risk is around 2 to 3%. Elective repeat Caesarean delivery. It should be performed beyond 39 weeks of gestation. RCOG recommends antibiotic use before skin incision and thromboprophylaxis. In those with placenta previa with a history of prior Caesarean section, a multidisciplinary approach should be taken with informed consent because of the risk involved. What are the risks of elective repeat Caesarean delivery? Increased maternal morbidity, increased length of hospital stay, increased risk of hemorrhage and blood transfusion, increased risk of abnormal placentation such as placenta previa or adherent placenta, hemorrhage and repeat Caesarean delivery in the subsequent pregnancies. Risk of anesthetic complications. Maternal death rate is around 13 in 1 lakh. Risk of neonatal respiratory morbidity is 4 to 5% if it is conducted between 38 to 39 weeks of gestation. However, this can be reduced by use of antenatal corticosteroids. Risk of hypoxic ischemic encephalopathy and perinatal death is less than 0.01%. What are the factors that are to be considered for trial of labor? The first factor is prior uterine incision. This includes the prior type of incision. The type and the number of prior caesarean deliveries are overriding factors in recommending trial of labor after caesarean section. ACOG suggests that most women with one previous low transverse incision are candidates for trial of labor, as these have got the lowest risk of scar separation. And if scar rupture does occur, it usually occurs during labor. The highest risk of rupture are those with prior classical or vertical incision. A classical scar is likely to rupture before the onset of labor, sometimes even several weeks before term pregnancy. So here we can see the estimated rupture rate with the type of prior incision. So in case of classical caesarean section, it is 2 to 9%, T-shaped incision 4 to 9%, low vertical incision 1 to 7%, one low transverse caesarean section 0.2 to 0.9%, multiple low transverse incision 0.9 to 1.8%, with a history of prior uterine rupture. In the lower segment, risk of recurrent rupture rate is 2 to 6%, and rupture in the upper segment, risk of recurrence is 9 to 32%. And in case of prior preterm caesarean delivery, there is an estimated increased rupture rate. Why is the lower segment scar said to be better? One, because the opposition is good because of the thin cut margins. This portion remains inert during the healing process. Stretching occurs in the line of the scar during future pregnancy and labor. There is less chance of placental implantation and also less incidence of rupture. The next factor is number of prior caesarean incisions. Some studies have reported a doubling or tripling of rupture rates in women with 2 compared with 1 prior transverse hysterectomy. Then imaging of prior incision. A study has grouped women into 3 risk categories for uterine rupture during trial of labor based on sonographically measured thickness of prior incision. It is said to be high risk if the thickness is less than 2 mm, intermediate risk if it is between 2 to 2.4 mm, and low risk if it is more than or equal to 2.5 mm. However, overall data in this regards are limited. Then, how the prior incision was closed. The rates of uterine dehiscence or rupture for single layer versus double layer closures of low transverse uterine incision does not differ significantly, although many studies have been going on in this regards. Next is prior uterine rupture. So this we have already discussed that women with prior history of uterine rupture are at greater risk for recurrence of rupture, and they should undergo caesarean delivery prior to the onset of labor. Next important point is the inter-delivery interval. If the inter-delivery interval is less than or equal to 18 months, it is seen that there is a 3-fold higher risk of symptomatic rupture during a subsequent trial of labor compared with interval that is more than 18 months. Next is prior vaginal delivery, either before or after a caesarean birth, improves the prognosis for a subsequent vaginal delivery. It also lowers the risk for subsequent uterine rupture and other morbidities. Then the indication for the previous caesarean delivery. Women with non-recurring indications like breech or fetal distress have got the highest rate of success in a trial of labor. The chances of uterine rupture is higher when the previous indication for caesarean was placenta previa, where the scar is usually weak because of imperfect apposition and thrombosis of the placental sinuses, or if it was done for prolonged labor where the chance of sepsis is more. Then multifetal gestation. As per ACOG, a woman with twins and a prior low transverse hysterectomy can safely undergo trial of labor, as twin pregnancy does not appear to increase the risk of uterine rupture. Maternal obesity. An inverse relationship has been seen between the pre-pregnancy BMI and the rates of vaginal birth after cesarean. In a study, VBAC rates of 85% was seen in a woman with normal BMI, 78% in women with BMI between 25 to 30, 70% with BMI between 30 to 40, and 61% with BMI more than or equal to 40. Fetal size. Increasing fetal size is inversely related to VBAC rates. A study showed 1% rupture rate for fetal weight of less than 4 kg, 1.6% for fetus weighing more than 4 kg, and 2.4% for fetus weighing more than 4.25 kg. Also, there is an elevated risk of failed trial of labor, shoulder dystocia, and perineal lacerations with rising birth weight. Fetal death. Most women with prior caesarean delivery and fetal death in the current pregnancy would prefer a vaginal delivery. In a study, it was found that women with prior caesarean with fetal death who went for trial of labor, the VBAC rate was 87% and uterine rupture rate was 2.4%. So, the dictum in 2016, which read, "Once a caesarean, always a caesarean," in the present era, it is, "Once a caesarean, always it should be an institutional delivery in a well-equipped hospital." So, coming to hospitalization. Now, cases with previous history of lower segment operation should ideally be admitted at 38 weeks of pregnancy to assess the lady completely and formulate the line of treatment. Whereas those with previous history of classical Caesarean section should be admitted at 36th week, as there is chance of scar rupture more during the last few weeks of pregnancy. Labor considerations. Spontaneous onset of labor is desired. Labor induction or augmentation is associated with 2 to 3 times higher risk of rupture and 1.5 times higher risk of emergency caesarean. The risk is, however, lesser with amniotomy. Now, what about epidural analgesia? The American Academy of Obstetricians and Gynecologists have concluded that epidural analgesia may safely be used during trial of labor after caesarean. Increased analgesia requirement should, however, arouse suspicion in us of impending rupture. So, how do we manage the labor part? An IV line should be commenced with RL solution. Blood sample is to be taken and sent for hemoglobin percentage, grouping and cross matching. Patient has to be monitored very closely all throughout. Labor monitoring is to be done clinically for scar dehiscence and also to ensure that there is a smooth progress of labor. If we find that there is a slow progress in the presence of strong contractions, it is an indication of dystocia and it greatly increases the likelihood of repeat Caesarean section. Continuous electronic fetal monitoring is usually desirable. Intermittent auscultation, if performed, should be done every 15 minutes in the first stage of labor and every 2 minutes in the second stage of labor. Prophylactic forceps or ventos is preferred to cut short the second stage of labor. Exploring the uterine scar after delivery for its integrity should not be a routine procedure. It is done only in selected cases when there is continued and excessive bleeding or maternal hypotension in spite of a well-contracted uterus. Scar rupture or dehiscence during labor. So how do we diagnose such a case? There is no single pathognomonic clinical feature to indicate presence of scar rupture or dehiscence. There may be abnormal fetal heart sound, bradycardia, abnormal CTG pattern such as variable and late deceleration, or a non-reassuring pattern. Then suprapubic pain, if it is severe and it persists in between contractions, may suggest dehiscence or rupture. There may be shoulder tip pain or chest pain or sudden onset of shortness of breath. There may be an acute onset of scar tenderness. Patient may even complain of abnormal vaginal bleeding or hematuria. Cessation of uterine contractions which were previously adequate is often found with a change in abdominal contour. Maternal tachycardia, hypotension, shock are also usually presenting features, and there may be loss of station of the presenting part. Management. Early diagnosis of scar dehiscence or rupture needs prompt laparotomy and resuscitation. With complete rupture, hysterectomy may sometimes be required. However, in selected cases, we may go for uterine repair with tubal ligation. With rupture and expulsion of fetus into the peritoneal cavity, there is a dismal chance of intact fetal survival. Mortality rates range from 50 to 75%. A study has showed that if the decision to delivery interval in case of uterine rupture is less than 18 minutes, there is a minimal risk of adverse neurological outcome in the neonate. Maternal mortality from uterine rupture is uncommon in advanced countries. However, in rural India, the maternal mortality associated with uterine rupture is still high as 30%. Next, we come to the recommendations of certain professional societies for trial of labor after cesarean. As per ACOG 2017, counseling should be offered to most women with one prior low transverse incision, and it should be considered in those with history of 2 prior low transverse incision. It should be conducted in a place which is safe enough with ability for immediate cesarean delivery. The patient should be allowed to accept the increased risk when this is not available. In twins, macrosomia and prior low vertical or unknown type of incision, these are not precluded. ACOG guidelines states that VBAC is safe and appropriate for most women with prior history of cesarean delivery. Women with 2 prior low transverse cesarean incision and those carrying twins may also be considered appropriate candidates for trial of labor. It is also not contraindicated for women with an unknown type of uterine scar. These guidelines emphasize the need for thorough counseling of benefits and risks and a shared doctor-patient decision making. Now coming to the recommendation of Obstetricians and Gynecologists of Canada 2005. Counseling is to be offered to women with 1 prior low transverse cesarean delivery. With more than 1 prior cesarean delivery, VBAC is likely to be successful, but the risk is more. Delivery should be conducted in hospital in which timely cesarean delivery is available and the approximate time frame being 30 minutes. Oxytocin or Foley's catheter induction is said to be safe. However, prostaglandins are not to be used. Macrosomia, diabetes, post-term pregnancy and twin pregnancies are not contraindications. Recommendations of RCOG 2007. Counseling. The VBAC option should be discussed with women with prior low segment cesarean delivery. It should be a shared decision between the patient and the obstetrician. It should be conducted in a suitable delivery suite with continuous care and monitoring, with facilities for immediate cesarean delivery. Caution is to be taken in case of twins and macrosomia.